Thanks, Peter. So I'm standing here in front of you, as Peter said, as the representative of the dementia, frailty and end-of-life care theme of the CLAHRC. And so the theme, just who we are, the theme includes folk from Cambridge who are involved in dementia and frailty and end-of-life work. From UEA, also basically University of East Anglia and University of Hertfordshire and the Cambridgeshire Foundation Trust. Cambridgeshire and Peterborough Foundation Trust. So in each of those locations, in Cambridge, we represent all of the angles of the theme. In UEA, all of the angles of the theme, and also in Hertfordshire. There's a very rich mix of disciplines across the whole region. So it's been a real privilege to lead this theme with all my colleagues, so many of whom are here in the audience, and also the team, the distributed team, are also in the audience. So any questions that arise after this session, please direct them to the team. So I'm going to give you a very brief overview of the projects that we have running and what we're thinking about in terms of impact. We've got feedback from the public, from our stakeholder event that we held earlier in the year, and some of you may have been at that too. And then we're going to have two very brief examples, the road study and the end-of-life care projects with other folk from the team presenting those very briefly. And then what we'd really like at the end of the session, then it depends on how much time's left, but we'll have a brief interactive session. And we'd really like to hear from those of you who are from the service provision, service commissioning angles about your reactions. And also, we've got some sort of questions which we'd like you to think about and maybe respond to. So, very briefly, the projects that we have running at the moment include population dementia risk reduction. This is building on the already well-established over really nearly a quarter of a century population-based studies of dementia and cognitive decline in the East Anglian populations, particularly in Cambridgeshire, and that's produced prevalence figures for the UK and England in the past, and can do currently as well. And there's a great focus from Public Health England now, and more generally about what can we do earlier in life and even indeed in later life to reduce the risk of dementia. And so this project is focused on that kind of work, and we are hoping that in due course we'll have a trial that will be able to, a very complex trial, that we'll be able to roll out in the context of our population-based studies. So that's work in progress. Project 2 is the impacts of dementia case finding. As many of you will, if not all of you will know, there's been a great deal of attention to dementia, including financial incentives for GPs, but the piloting thereof. So various policies have been implemented, including screening for dementia in hospitals. Much of this is not based on trials or formal health services research, but more of an enthusiasm and a concept that we haven't identified all those people who meet the diagnosis of dementia in the community, and that it would be a good thing if we did. So this project builds on those policies in order to see what's happening on the ground and how it's working. And so that's just starting up, and it's an evaluation of the variety of case-finding mechanisms that have popped up, if you like, as a result of the policies coming down from on top, because we're very aware that the policies have been met in very many different ways across the region and the country. The third project is Edwina, Eating and Drinking Well in Dementia. And this deals with the very real problem of caring for people with severe dementia in terms of their nutrition. And we're very well aware that people in hospitals, older people in hospitals and in various settings, become malnourished. And if you have cognitive impairment, and particularly if you have moderate to severe dementia, this is going to be a much bigger problem. And so this project has begun by reviewing the evidence on interventions and the approaches to supporting eating and drinking well with dementia, with a view to going on to intervention trials using the best possible evidence. Project 4 is understanding hospital admission close to the end of life. It's the ACE study, looking at where patients die and whether that's their place of choice. And this builds on established work which has been going on across the region for people who are coming towards the end of life, and some also the population-based studies which have tracked where people move around before they die, showing that this very large proportion of people who move into hospitals, and that if you're in a care setting, you tend to stay there, and actually the quality of life is rather better before death. Or the quality of death, I should say, is rather better. So this is that you'll hear more about this shortly. Research into older people with dementia and their carers, use of emergency ambulance services. It's clear that ambulance services are a very critical factor in the way that people move around between primary, community and secondary and even tertiary settings, and that dementia plays a role in the way that people move around into service settings, particularly in acute emergencies. And so this work is building on that knowledge, and it's a really critical part of the health system, and it's sort of in a bubble. Its data sets are in bubbles, separated off, and we'll hear about this from Marina Buswell later as well. So those are the major projects, and we are interested in the impact, and we're working on the impact in terms of the research outputs and activities. So if we generate new grants and so on, so I've mentioned about trial generation, trying to advance knowledge, but we have to do trials often as a result of the preliminary work that we do. So knowledge advancements generally, so there'll be things that we can garner from the work that we're doing for current services, as well as trying to implement more research. So no, it's not just more research, please, from the researchers. I know that's what we're often, what we can be accused of. So the idea of working out what is usable now and what do we need more evidence for. And then if we do have things which are what is usable now, there's the whole element of practice implementation, and that's clearly a very challenging area, the whole area of implementation, research itself and action. And then some of the work that we do is relevant to legislation and policy, so that the population-based work is relevant to high-level policy estimation of numbers and the way people flow and the way that we might organise our, say, transport systems. And then community benefits, working with the community to see how we can implement research findings or work with community, with co-production, and this is where the PPI comes in and community engagement, local authority engagement, very important. How can we work together to say, here are our research results, how can we work together with this community in a way that this community values and wants to as it were, implement the research. So it's not that it's a given, we're not imposing, but actually co-producing, as Peter has described for the CLAHRC as a whole. So we had a stakeholder event directed purely to the dementia, frailty, end of life theme earlier in the year, and our feedback, we thought it would be helpful to provide the feedback from that here today. And there was a tremendous interest. In fact, we were oversubscribed, and everybody piled into a very hot lecture theatre, and were very, very tolerant of the conditions. So what their feedback was that there was a really strong interest in what we were doing, that they liked the idea of these diverse studies but actually under a common theme, and that the interaction between the groups was welcomed. So the research multidisciplinarity, but also the interactivity between the projects, and that we should do more of this kind of work, and we should certainly have more sessions where we had stakeholder engagement, so a chance to talk, as it were. And so the areas for improvement, not surprisingly, more time to talk, and structured debate to try to involve different constituencies, and more use of social media. So those were the strong feedback from our event itself. So now I'm going to step aside, and I'm going to ask Marina Buswell from the Roads team to give you a quick skate through what's been achieved in that project. Or those projects, I should say.
Yes. Thanks, Carol. So I really am going to give you a quick whiz through our study. So Roads was a development project, and it actually began life a number of years ago as a CLAHRC Fellows project, and it has continued with a CLAHRC Fellow working on it now, and that CLAHRC Fellow is Phil Lombard from the ambulance service, he's an emergency care practitioner, and he's now the Assistant Director of Urgent Care in North and East Herts CCG. So we've had a lot of involvement from with service from the start. So this was a one-year study, and it has, you can see up here, 4 elements to it. So the first element was this evidence review, and we've done 2 parts to this review, and the first part's published, and that's where we've looked at the role that ambulance services play in looking after in the urgent care of people with dementia. And there's actually not a lot out there, but one of the things we came across was quite a narrative around the sort of last resort safety net role they play. Then I've done a record review, and this review was looking at ambulance service data. And as Carol said, it's quite different from other data. I wanted to quantify existing patterns of service use, look at what proportion of people have dementia actually recorded in the record, and whether people... Is that better? Whether people are at home or in the community, and obviously trying to look at conveyance to hospital, because people are always interested in that. Then we did a study of a local service in Cambridge, and we didn't actually evaluate the service, but we're asking, how is this service, how do they care for older people with dementia? And then finally, another colleague, she did some critical incident reviews, really trying to understand what factors are associated with call-outs to older people with dementia, and looking at different, a lot of different people and a lot of different scenarios. And a key part of this study, as Carol said, was we would take findings to a stakeholder meeting to try to bring together our emerging findings and pull out what the themes are coming out. And this meeting had paramedics and community clinicians, family carers, paid carers of people living with dementia, ambulance service and University of Hertfordshire patient and public representatives, and it also had commissioners, both CCG and local authority. So it's a good lot of different viewpoints looking at the work we'd already done. So what have we done? Well, here's some initial outputs. It was a development study, so we want to take the work forward, and part of that, I'm going to be a co-op on a bid that is actually happening down in the west of England, and it's home or hospital for people with dementia and 1 or more multimorbidities, the potential to reduce avoidable emergency admissions. So very much along the same theme, and they actually found me through the paper of the review that we published in the EMJ, so that was a good connection there, and they're hoping for my input on the data side of things. Also, I didn't actually publish... This article in the HSJ came out from the team. They got asked to write an article for the HSJ, and actually, because I was working with a team, we'd already written up some of the findings I'd had from interviewing the team, and I helped them do stuff with their data, like confidence intervals and things on that. And then this other paper we've got out actually came out of the stakeholder meeting, so we weren't planning this paper, but there was an off-the-cuff comment by a paramedic about how they use records, and we investigated that, and we found there was something in that. So I'll tell you very quickly about each of these areas. Oops, sorry. So the data. So I did a record review of 358 paper-based records, and yes, it is paper-based records. They have electronic records as well, but they use both, and we had to look at paper, so that took quite a lot of time sitting there for a couple of weeks in Bedford Ambulance Station. So from the call data, we found that over a third of call-outs in the sample we looked at were to over 75s, and then in the actual records we looked at least 15% are to older people with dementia, so they had dementia recorded in the record, and around 15% were to people living in care homes. And the thing with the I'll show you actually, this is what they've got paper records like this that we're looking at. There's no box to tick for dementia, it's just free text. You're just looking for free text somewhere. So what we did to ensure that we're really picking up dementia is we just looked at if it definitely said dementia or vascular dementia or Alzheimer's. If it had a question mark or a query, we didn't include that in that 15%. And there was another 7% where there was queries about cognitive impairment and dementia. But what we're able to do is compare this prevalence in the ambulance service records with the CFAS data. And the blue is the ambulance service records, the olive is the CFAS, and basically it's in line with the prevalence estimates from CFAS. And I told you again about this little bit of information that came from a stakeholder group. So we said, oh, well, our transport rates from that data is about 60%. But a paramedic said, yeah, but if we're leaving someone at home, we'll probably do a paper record. And if we take them to hospital, we'll probably use the electronic record. We're like, oh, and actually because we're working with a CLAHRC fellow who was doing an elderly care audit, so this is a different set of data, he was able to give me anonymised data just to check that out, and it was a difference. If you looked at the electronic data, then you'd think 5% are left at home and 85% taken to hospital. And the paper records, you'd think a third are left at home and 50% are taken to hospital. So we've just published that in a small correspondence because it's just a caveat. If you're looking at ambulance service records and you're using a mix of both, it's important to know that your conveyance rates, you need to be aware of that. And then there's another section, these critical incidents reviews, which my colleague Sarah did. And it's using this kind of idea of thinking about what's happening before you call an ambulance. And so this is, this is a wife of somebody who has dementia, and she's thinking about what happened before we called the ambulance. So a week before, you've been to the GP, a day before, going to the GP again, husband didn't seem very well, phone the GP, they say call an ambulance, still don't seem to be able to make them understand they should come out. And then a paramedic arrives, and I'll whiz through this, but basically they end up in hospital, have an examination, and end up going home. So it wasn't too traumatic for anybody, but did all that need to happen? This is a much sadder case. So this is a senior carer recalling someone in their care home, and they're thinking in the month before, what happened in the month before we called the ambulance? The resident wasn't very well, then they seem to be okay, then they take a turn for the worse, and the GP visits, and then they're calling the out-of-hours GP. They're waiting for the out-of-hours GP, so then they think, let's call an ambulance. And although there was a decision not to resuscitate, the ambulance did that because it wasn't properly recorded. And so, sadly, they find out that the person died in the ambulance on the way to hospital. So it's very two different scenarios, and there's a lot of different scenarios using this methodology. And then finally, we looked at this team working in Cambridge. And this team's a bit different now because that's what happens when you're working with local teams. They don't exist in the same form. But really, they're just telling us about their model and how they think their model works with elder people with dementia, because they're just for older people with urgent care needs, and they're saying they needed to do a bit more around recognising dementia. And they're very keen around safety, rapid response rather than admission avoidance was their thing. And really, and that they had a lot of time to spend with dementia patients, and they felt that was a difference. But of course, that's just a service perspective. You have to remember that. We're not interviewing carers or patients there. So really, that's a total whiz through. I know we've whizzed through that. I hope it gives you lots of questions to think about. But there's a wide spectrum of experience of emergency ambulance service use, from pre-diagnosis through to end of life. And so emergency service and staff need very different types of skills, knowledge and resources, depending where the person is along the trajectory. And this stakeholder meeting was really key. And as Carol said, the link between primary and secondary care and the ambulance service being a key player came out quite strongly. And some people hadn't really thought of the ambulance service like that. So we really need to look at dementia trajectory sensitive interventions, and particularly about how paid and unpaid carers can contribute to decision making. That came quite strongly at the meeting, that they felt a bit out the loop. So we need to think about interventions that support the involvement of ambulance services in the whole picture. And also that the secondary data analysis, that's just a partial account. You know, we need to be careful when we're using data. And this is the team, and that's our whiz through. Thank you.
Thanks. Okay. So if you could hold or make a note of your questions or things that you thought about while Marina's been speaking, and just hold them until the interactive session at the end. So I'd like to introduce Jackie Buck now, who is going to talk about the end-of-life care projects.
Thank you very much. I'm here to represent, there's 3 of us in our end-of-life care group that have funding at the moment by CLAHRC, Mila Petrova, Sarah Hoare and me. And I've got 10 minutes to give a brief overview of the 3 of our studies. So this is just a snapshot of what we've been up to in the last year or so using our funding. The first project I'll talk about is Mila's. Mila's project is called Prepare to Share. And it's a project which is evaluating an interface that has been implemented across the Cambridgeshire and Peterborough CCG to allow clinicians in primary care to share information with clinicians in secondary care. We know that often when end-of-life care doesn't work very well, it's due to poor communication. And so this is to try and help people to achieve better deaths by allowing people to speak to each other when they're not there. So essentially what happens is community nurses, GPs, specialist nurses input data onto a template around things like whether conversations have been had about resuscitation, what kind of painkillers, treatments, medications patients are on. And that information is accessed at the secondary care level, but in A&E or by ambulance crews or out-of-hours services, so that people who are at end of life don't have to have those conversations repeatedly, or their carers. And the whole point is to try and minimise distress to people and to reduce inappropriate hospital admissions at end of life and ensure that people are looked after as well as we can. At the moment, Mila is still carrying out the evaluation of this intervention. She's just carrying out the last few interviews, doing some data analysis and writing up. So I haven't got any results to present from her today. This kind of interface has been set up in a few areas, and so she's getting together with a couple of other people who've been doing it to host a conference in Cambridge next month. If anybody's interested, please get in touch with her. The next project I'm going to talk about is one by Sarah Hoare. Sarah runs the ACE study, which Carol mentioned, and Sarah's a PhD candidate who's funded by CLAHRC. And the most recent thing she's been looking at is around preferred place of death, and she's carried out a systematic review. And she's really looked at taking a closer look at the data behind the preferred place of death data that we see. This is important because it's become generally accepted in the media and in policy, this is a policy document from 2013, that majority of people, if given a choice, would want to die at home. This data generally comes from 2 sources. The first is from public opinion surveys such as Ipsos Mori, that kind of thing. And the second is from research studies of people who have got life-limiting conditions such as cancer. And what the team noticed is that a lot of the research studies where people have been asked where they would like to die have an awful lot of missing data. And so they decided to take a closer look at those studies by doing a systematic review. Essentially, Sarah found, through a long process, which I won't go into details, but she found 58 papers where people had been asked about where they would like to die and state their preferred place of death. Now, this slide, she's taken those studies and categorised them according to illnesses. So the section over on the far side is patients who have got cancer, so studies of patients with cancer when asked about where they want to die. The second section is patients with multiple comorbidities. The third is people who don't have cancer, but we don't know what they do have. The fourth is just people where their illness wasn't stated. And then this last section closest to me is public, so opinions that have been asked of the general public. And what she found, this red line here, represents the median of people who have said that they would like to die at home, so when they've been given a choice. And as you can see, it's between 60-70% of people across the board have said, when given the choice, they would prefer to die at home. But when she added in the missing data, that reduces quite rapidly and quite significantly across the people with life-limiting illnesses, down to 30-40% of people said that they would like to die at home. That wasn't found in the public because there was far less missing data in any of those studies. Now, of course, we don't know what the this missing data, we don't understand it, we don't know why it's there. We don't know if perhaps they would have all chosen to die at home and the figures would have been the same, we don't know. Sarah has speculated that there are perhaps 3 reasons why there is so much missing data. One is that perhaps some people just weren't asked if it was maybe felt to be inappropriate at the time, we don't know. The second is quite important, that maybe some people just didn't have a preference. And that wasn't recorded anywhere. They weren't able to record that they didn't have a preference. And the third is that perhaps some people just weren't able to talk about it. But Sarah would assert that in future studies where people are asking about place of death and preferred place of death, that not having a preference for death should be place of death should be taken into account and should be seen as a legitimate option. So that's what Sarah's been up to recently. And of course that perhaps should be feeds into policy and what have you, so she'll be publishing this pretty soon, I think. The third study is the one that I'm involved with. I've been funded for 1 year with RCF funding from CLAHRC to develop a research proposal and crucially to get funding for it we're hoping to get funding from Research Patient Benefit for a project looking at, quite a difficult project, looking at how and when to stop certain oral chemotherapy drugs for people who are close to end of life. This is working across Cambridgeshire and UEA. We've got Tony Arthur here, and I think Gary Barton's part of our research team who's be here later, and many others as well. Just to give a little bit of background, it's been in the news a lot recently that cancer therapies are changing quite significantly, and we're particularly looking at some targeted therapies, which are drugs or other substances that block the growth and spread of cancer by interfering with specific molecules that have something to do with the growth of spread. This is quite different to traditional chemotherapies because these drugs don't kill cancer cells, whereas traditional chemotherapy, people come in, they have chemotherapy, it kills the cancer, they go away and perhaps it comes back again. These aren't designed to do that. They're designed to try and stop the cancer from growing. We're particularly interested in the oral forms of these drugs. Some of them are given intravenously, but we're particularly interested in looking at the oral tablets because what this means is that people are having chemotherapy at home as tablets. Because they're not cytotoxic, then they have far, far fewer side effects than standard chemotherapies. Now, 5 years ago, these therapies weren't available and there would have been nothing that we could offer people at this point. The survival of these drugs at the moment are about 6 to 9 months for lung cancer, 9 to 12 months for melanoma, but it can be a couple of years for people with renal cancers. What's significant, though, is that we don't really know when to stop them. As people approach end of life, with traditional chemotherapies, it's considered a quality indicator that people should definitely not be on chemotherapy within the last month of their life. And it's generally accepted that you should stop any systemic anti-cancer therapies when there's any evidence of illness progression. But the question is, does the same remain with this type of drugs? And the reason that's quite important is because there is some evidence that some people, even when the tumour starts growing, they can remain on these drugs quite well and then it eventually takes over and they die. But if you stop them, for some patients, when the tumour starts to grow again, they rapidly decline in something called disease flare. So you stop taking the drugs and they go downhill very quickly. So we just don't know when we should stop these drugs as people approach end of life. And one of the questions is, does it matter? Could we keep people on these until they die? And that might be one of the findings. But at the moment, we do know that there needs to be a bit of a transition time between secondary care and primary care in order to arrange end-of-life care for people. And currently we know that there are delays in this at the moment. So sometimes people are on these drugs, clinicians know they're not working anymore, but there needs to be some kind of transition time for people to stop taking them, for everybody to prepare for people to die. And it's a kind of marker that therapy's ended and this is the time that you need to start preparing the system and for people. We know that generally the longer people stay on chemotherapy, the less chance there is of them dying in their preferred place of death, which just bears that out really. And we think everybody needs time to prepare for death. We can't ignore that these drugs are incredibly expensive, anywhere between £2,000 to £8,000 per month. and quite a few of them are funded through the Cancer Drugs Fund, and we don't know what's happening with that. It expires next year. So there's the whole question of individual versus societal benefit. It's quite a complex matter. The goal of this project, if we get funding, will be to develop some evidence base around when to stop these drugs, in the form of a toolkit of web and written information for carers and clinicians, crucially clinicians. This is a project that came about from clinicians coming to us and talking to us about this project. Every day they're faced with this. They just don't know when to stop these drugs and how best to do it. And of course, these are very difficult conversations. And we want to produce guidelines for clinical practice. I'm not going to go into the methodology because we haven't really got much time, but we're doing triangulation of methods. We're doing lots of different things to try and approach this from several different angles. We're doing also using some health economics in there too. I've got a poster out there with this on it, and I'm happy to talk through the methods in more detail if anybody's interested. And that's it really. That's just to let you know what the end-of-life care theme have been up to with our CLAHRC funding. Thank you.
Thanks, Jackie. Thanks. Okay, well that gives you a flavour, a more detailed flavour of two of the areas of work of our theme, and that's just the folk that Jackie's already mentioned.